Doctor, we are live now, Doctor.
Okay. Good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today evening. It gives me immense pleasure to welcome you all for the 8th masterclass of the online postgraduate teaching program, which we have named Kaksha. Kaksha is the PG teaching program by ROS, which will cover all the major topics of post-graduation current curriculum in India. We'll be bringing the best of national and state faculty experts to share their expertise, knowledge, and interact with you. The residents are also encouraged to put forward their doubts in a fearless manner. In between the class, you can type your questions, raise your hands, and the speaker and all the moderators and the panelists will be happy to answer your queries. Coming to this class, we have today with us my good friend and senior, Dr. Ankur Sinha from Jaipur, to teach us a simple way to interpret all these, complex looking black and white printouts, the visual fields in glaucoma and neurology. So Dr. Ankur Sinha is an eminent glaucoma specialist of national and international repute, and he is the director of Max Vision Eye Center in Jaipur, and he has done his post-graduation and senior residency in glaucoma, symptomology, and neuro-ophthalmology from RP Center, All India Institute of Medical Sciences, New Delhi. He has been the past executive of Glaucoma Society of India. He has been the past treasurer of Indian Pediatric Glaucoma Society. He is the current treasurer of SPOCI. I welcome the ROS President Khilani sir, President-elect sir, Dr. Sanjeev Desai, and our dynamic secretary, Dr. Ghulam Ali, for today's class. And as usual, we have few residents on the hot seat. Today's hot seat residents are Dr. Tamanna. Tamanna, are you there? Can you say hi?
Yes, sir. Hi. Good evening, sir.
Dr. Ayushi from Udaipur.
Yes, sir. Good evening.
Mukesh from Udaipur.
Hello, sir. Good evening.
Tamanna, Ayushi, Mukesh are final year postgraduates from different colleges in Udaipur. And there will be a grand quiz with exciting prize at the end of the Kaksha. So keep a strong vigil and listen carefully. The speaker is also, the teacher is also requested to interact freely with the residents so as to make it a more enjoyable experience for them also. Over to you, Ankur sir, for your presentation. You can start sharing your screen now, sir.
Thank you, Vishal. So what has happened? Okay. Is my screen visible?
You are visible.
नहीं सर, अभी स्क्रीन शेयर नहीं हुआ है.
What has happened?
शेयर स्क्रीन दब रहा है ना आपके?
आ तो रहा है.
Manjula, can you help Dr. Ankur in any way to share the screen?
Pardon, Doctor?
Quit and reopen. I'll have to quit and reopen. I see.
He's not able to share his screen.
Okay, Doctor, we'll check.
Sorry for the technical error, residents. We'll be sharing the screen in a couple of minutes.
You can share, Doctor. It's working fine.
Ankur sir, try again.
Doctor, it's working fine, Doctor. You can share.
It's Is it closing again and again?
Ankur, you are mute.
Yeah, अभी आया था.
Yeah, abhi aaya tha.
Is it seen now?
No.
No.
What has happened?
It
Doctor,
came
you
to us.
open your file on desktop, doctor, then you can start the sharing.
No, it's on desktop. It's running on desktop.
Okay, but you are sharing the Zoom again, doctor. It's not sharing.
Now,
No.
participants can
Can
see
see your screen, but the screen is not visible. Now, yeah, see, yeah, it's background.
Yeah. Okay.
Is it okay?
Yeah, you just slide
Yes.
through a few slides. Just scroll through a few slides. Yeah.
But I can't.
Yes,
But I
yes.
can't see you, or I can just see my screen.
Yeah, that's okay. That's okay.
That's okay. So somebody will have to tell me the questions if there are any.
Yeah, I'll moderate. I'll tell you the question. You proceed.
Thank you, Vishal, for this opportunity, and I'm sorry for this small glitch we had right from the beginning. So I'll carry you all through a session on perimetry. So first 7 to 10 minutes can be a little boring because we'll be talking about basics of perimetry, how the perimeter works, and how we should be administering a visual field to a patient. So, we all know that the basics of all the investigations are a little boring. Then we will talk about how to read a single field, and then we'll talk about various types of visual fields we encounter and the problems the patients face. So let us start with the basis of any investigation. So basis of any investigation is to understand and define normal, because on the basis of that, we define what is normal. To understand and define the disease, to compare normals with the abnormals, that is the disease versus normals, and to tailor the dose of treatment for that particular disease. This is how we should have, any investigation which is required. And this is the basis of almost all the investigations. So visual fields, when all of us, when we look at something, we can see everything in front of us, not behind us. So the area which is visible is what is the visual field. And by visual field, we tend to determine the outermost boundary, what we can see. So you can see in this figure here, we can see 60 degrees up, 70 degrees down. So up is limited by the brow, down is limited by the cheek. 60 degrees nasally, again, we have a nose which is encountering us, and then temporally we can say around 100 degrees. So this is what is the normal visual field of each eye. And when we see binocularly, so central 120 degrees is a visual field by both the eyes, and the lateral 30 degrees on either side is by the either eye. But determining the outermost boundary is not we want for glaucoma, because the glaucomatous visual field defects are very, very much in the center from around 10 to 20 degrees or maybe 10 to 30 degrees area. So visual field ideally should be a function of retina at each and every point. So we all know that for every point in retina, there is a corresponding point in the visual field. And a nerve fiber layer loss or a retinal damage at a particular area would leave a defect in that particular area of the visual field. Now, ideally, we should be able to measure the visual acuity at each and every point on the retina. So for that, we have to fix a gaze, and we ask the patient to read a letter around 10 degrees or 20 degrees away from that fixation area. But this is not practically possible, because we know that as we go away from fovea, the visual acuity decreases very sharply. So we all know that if there are macular lesions, central macular lesions, the visual acuity drops from 6.6 to 6.18, or maybe even less if the central area is central damaged area is little larger. Now there is a concept of halo of vision. So this is the central area, as my pointer is pointing, where the fovea is. And as we move from center to away in all the four directions, the sensitivity of retina decreases. So this hill represents how the sensitivity of retina decreases as we move forwards from the fovea. And this representation in 3D form gives you or creates something called as hill of vision, which is there and which is what we want to measure in glaucoma. Now, quantification of visual field requires a quantification of halo of vision, and there are various factors which can influence the quantification of this. That is the visibility of white spots. If you're talking about a white spot, the apparent size, we all know that the larger size or larger objects are seen early as compared to smaller objects. Luminous intensity, that is the larger or the bright objects which have higher intensity of brightness, are seen easily. Background illumination, we know that the illuminated background, we can see the objects very clearly as compared to dark backgrounds. And the duration of stimulus, if a stimulus is presented for a longer time, we see. And if the stimulus is less than the retinal sensitivity time, then we are not able to see that stimulus. Then color of stimulus alters the perception, attentiveness of the patient. We all know that sometimes the patient is having an eye open and we are daydreaming. So that is an inattentive patient with open eye. We cannot see. Refractive status and movement of the stimulus. This is called as redox phenomenon. This can come as an MCQ. We all know that the moving objects are seen better as compared to stationary objects. Now we talk about the apparent size of the stimulus. So as we move from the center of the fovea to away from the eye, the apparent size decreases. So any spot size of 3 millimeter at 1 meter away from the eye, or 6 millimeter spot size 2 millimeters away from the eye, or a 1 millimeter spot size about 33 centimeters from the eye will apparently look similar as we move forward, because they will subtend similar kind of angle onto the retina. Now this distance for all perimeters is fixed, that is 33 centimeters, especially for HFA. Now this is a table which summarizes various types of stimulus size used in almost all perimeters. The size varies from 0 to 5. So as we go from 0 to 5, the size increases in 4 times, say 1 to 4 times, 4 into 4, 16, and 16 into 4, 64. So this is how this size increases. And this is the area which subtends, the angle which subtends on the retina. This is the angle which is subtended by each spot size on the retina. So this is the blind spot, and this is the relative position of all the spot sizes we have, 1, 2, 3, 4, and 5. So even the 5 stimulus is much smaller than a typical blind spot we have in the visual field. Now we talk about the light intensity, which is measured in apostilles. So apostilles is the brightness of light we measure. So HFA has 10,000 apostilles as the background stimulus, while octopus has 1,000. So we can see that the HFA has 10 times more brightness as compared to octopus. These two fields are the most commonly used fields in the world. These light intensity are then attenuated by neutral density filters. Attenuation means decreased. So what we do is we apply some dark filters, which are neutral density filters, and they reduce the intensity of that stimulus. And this is counted in log units, and 1 log unit is equal to 10 decibels. So what happens once we put a neutral density filter, which is measuring 1 log unit, we decrease the intensity by 1/10. Once we put 2 log unit or 20 decibels, it is reduced by 1/100th. So this is not a linear scale. It is not going like 1, 2, 3, 4. It is going like 1/10 and 1/100th. So 2 log decibels is not half, but 1/10 of what we are talking about. So these decibels are relative. So it is causing this 1 log unit is 1/10 of this maximum intensity of HFA or a maximum intensity of octopus. So the log units for octopus, say a 5 decibel decrease would be 316 apostles. For HFA, it will be 3160 apostles. So HFA is 10 times more stronger as compared to the stimulus of HFA is 10 times more stronger as compared to HFA. So a 15 decibel drop in one instrument is not equivalent to a 15 decibel drop in the other instruments. So this is how you have to be very, very sure that what type of visual field we are looking at, which is coming from which perimeter. Now, visual field explores the differential light sensitivity throughout the field of vision. That is, which area is perceiving which kind of intensity. So for this, we call this as a static threshold perimetry. The static means that the object is not moving, and threshold means that at what point the patient is able to perceive that stimulus. So we gradually increase the intensity of stimulus till the time his patient is perceiving. Above the threshold is called as suprathreshold, and below the threshold is called as infrathreshold stimulus. Now this HFA takes about the weakest stimulus seen as the point where the patient's readings are taken down. So a threshold stimulus is where the patient is seeing the stimulus 50% of times. So as we gradually decrease the intensity of stimulus, the patient stops seeing the stimulus. So that particular stimulus, which is seen 50% of times, is called as threshold stimulus. So HFA takes the weakest stimulus seen, while the octopus takes the average of weakest seen and the strongest not seen by the patient. Then there is something called as 4-2-1 bracketing. Now this can be a question which can be asked by examiners, how the visual field perimeter assesses the vision. So now visual field. So suppose there is a -6 decibel which has been presented, and the patient sees that stimulus. So the perimeter drops this gradually down to a level where the patient is not seeing the stimulus. And once the patient is not seeing the stimulus, it increases the intensity by 4 decibels. The patient sees the stimulus. Then again, the perimeter drops the stimulus by 2 decibels. Then the patient says it is not seen. And then the again increases by 1 decibel. So this is called as 4-2-1 bracketing, where the patient, in the standard or the threshold perimetry, the perimeter tends to find out what is the exact intensity of stimulus which is seen by the patient. Now, Background illumination affects the threshold. It determines the light versus dark adaptation. So background illumination is standardized in almost all perimeters. Now, what is the duration of stimulus presentation? So any stimulus which is presented up to 100 milliseconds is not seen by the retina because it is less than the threshold sensitivity of our retinal image sensitivity required for that. So, and the latency of eye movements is 300 milliseconds. So once we see a stimulus and we tend to move our gaze towards it, it requires 300 milliseconds. So most of the perimeters have this 200 milliseconds as a fixed duration of stimulus presentation because this is adequate for seeing the stimulus and this is inadequate for movement of the eye also. Now, these are the various test strategies which are available on white perimeter. White on white means the background is also white and the stimulus is also white. Then we have different kinds of perimeters like blue and yellow, where this perimetry has blue targets on a yellow background. So this is a typical 30-2 printout. This 30 means we are measuring 30 degrees, like 10 degrees, 20 degrees, and 30 degrees from the center, which is fovea. And 2 signifies these spots are on either side of the midline. So 30-1 strategy would have points right on the midline. And we all know that there is a horizontal raphe for glaucomatous visual field defects and a vertical raphe for neurological visual field defects. So if the point is right on the raphe, it may be inconclusive. Sometimes it may be seen, sometimes it may not be seen. So this 30-2 strategy has been moved away from the midline, and this is 3 degrees from the midline, but these points are separated by 6 degrees from each other. So they are 6 degrees apart, and there are 76 points in all in this 32-2 strategy. This is good to detect visual fields defects in glaucoma and also for follow-up. This is an optimum balance between sensitivity and time. Then there is 24-2. It takes around 24 degrees from the center. But on the nasal side, it takes a little larger, which is around 30 degrees. But on all other sides, it takes 24 degrees from the center. So it has around 54 points, which are again 6 degrees apart. So this reduces a little bit of time. So those patients who are not able to perform 30-2, 24-2 can be performed. And some glaucoma specialists tend to perform these kinds of visual fields only because they feel 30-2 takes a longer time. Now take care of the patient comfort. Now in this case, the patient's chin is little away and this patient is not going to stabilize this chin on the chin rest. It is going to be uncomfortable for the patient. So this is the incorrect way. And this is the correct position of chin where it is particularly abutting the chin rest. This is the position of lens, which is very close to the patient. This is away from the eye. So this is giving you only 20 degrees up and 20 degrees down. So this is going to give a peripheral constriction of visual field, which is not correct again. So this is the way the lens should be as close possible to eye, giving around 40 degrees up and 40 degrees down, because we are measuring 30 degrees up and 30 degrees down in almost all up, down, right and left. I meant that way. This is the incorrect position of lens where the eye is not centered, and this is the correct position where eye is centered. So I request all the residents to go to the perimetry room, try and administer a visual field on any of the patient on your colleague. Also try and do a visual field on your own for yourself so that you know how the patient performs and how the patient experiences the visual field. Now this is something about the test speed, that is the speed which these stimulus are presented. So for differently abled patients and elderly who are not able to respond in time, you can slow down at least in the HFA. And it is important to understand once we realize that the patient is not performing well, you can slow down the speed when that test is in progress also. So you can just pause the test and shift it to a slower mode. Now, then there are central fixation target. Normally for glaucoma, we tend to use this central yellow light, which is there in the perimeter as the fixation target. And then there can be a small diamond, which is required for all those patients who are not able to see the central area because of macular degeneration. And a large diamond can be used in a patient who is having a large central scotoma. And the bottom LED can be used for the patients who are having superior visual field defects. Also try and put appropriate lens power, give generous addition because we don't want patient's accommodation to be used. And any cylinder which is more than 1 diopter should be placed in the proper axis for all. So do a good refraction for near correction, especially for the patients who are 40+, and then give a proper kind of prescription into the trial frame of the visual field. So this must have been a little boring because this talked about the various basic things we talk about for visual fields. Now we move on to analysis of a single visual field, that how do we read a visual field. So this is normally a visual field printout, which is kind of offered to you for reading even in the exams. So we divide, for reading purpose, we divide the visual field into seven areas. So the first area is the procedure information in the patient data. The second area is the reliability indices. The third area is the grayscale and the numeric data. The fourth area is the total deviation and the numeric probability plot. The fifth area is the pattern deviation and the numeric and the probability plot. The sixth area is the glaucoma hemifield test, global indices, and the VFI. And the seventh area is a Grace tracker. So this is the routine you have to follow, and you have to go from 1, 2, 3, 4, 5, 6, 7. And you can easily remember that we are going from top to bottom. Now we will talk about importance of each and every area of the visual field, which is to be read when we are inferring data from visual field. So first of all, look at the name of the patient because it is important. We are seeing the same visual field as the patient who is sitting in front of us. Check for the ID of the patient because there can be a situation where when there are two patients with the same name, but the ID will be different in your hospital. Check the eye which has been examined because you're looking at a right eye. The right eye field has to be examined. Check there is correct date of birth which has been entered because the visual field perimeters, they compare the patient with the age matched normal. So the age is important here. As the retinal sensitivity also changes with the age. Check for the date and time of exam, and also check for the time required for each visual test, visual field analysis, because a larger duration required for the visual field test means the patient was very uncomfortable and the field may be unreliable. Check for the refractive error and the proper refractive correction has been placed. Check the pupil diameter and also the visual acuity. Check the test strategy which has been done. A CETA standard can be compared with CETA standard. CETA fast can be compared with CETA fast, and CETA faster by CETA faster only. Check the stimulus size. Normally it is fixed at size 3 with white perimeter, but sometimes you can increase the stimulus size in patients with poor visual acuity. Check the type of the program. One thing I want to mention is if you change the size of the stimulus to 4 and 5, you may not have age matched database, and then the visual field may not be comparable with the age matched database. Now check the type and strategy. You can have 34-2, 24-2, 30-2, 24-2, or 10-2 strategy, depending upon the advanced visual field defects or early or a moderate visual field defects. Now CETA standards takes a larger, more time as compared to CETA fast. And then there are new strategies in the terms of CETA faster, which are less time consuming. Also, we all know that as you move from standard to fast to faster, there may be small amount of information which can be lost in these patients, in these tests. Now we move on to reliability indices. How do we read these reliability indices? Now, first of all, it talks about the fixation monitor. Fixation monitor means how well the patient was fixing at the fixation point, which is the central yellow point, which was asked by the patient to be seen during the time of the whole test. It is the perimeter maps the blind spot in the early times and early on in the visual field, and it determines the fixation losses. So what the perimeter does, it gives you a stimulus at the blind spot, and the patient is not supposed to respond. If the patient responds, then there's a fixation loss. Fixation target is usually a typical central light, which we have discussed about and which can be changed depending upon the macular condition, the poor visual acuity. The upper limit of acceptable fixation loss is nearly 20%. Then we have these false positives. The upper limit of false positive is 15%. Now, false positive means the patient is not seeing the stimulus and pressing the button. Now, this is associated with high threshold values. That means the patient is seeing much less intensity of light, which is seen by a normal person. So this will have a very high threshold value for the first few points. The mean deviation, that is how it is deviating from normals, will be very high. That means the patient is supposed to have a very high retinal sensitivity, which can again be a problem. This could lead to a lengthy testing because the patient is responding erratically. The GST would label this as abnormally high sensitive patient or abnormally high sensitive retina. There would be larger defects in the pattern deviation than the total deviation, because we'll talk about this pattern deviation, total deviation little later. But you have to remember that high false positives can have larger defects in the pattern deviation. Then we move on to the false negatives. 33% or more may be significant, but some people consider 20% or more as significant. This occurs, false negative means that the patient is not pressing the stimulus even though the patient is seeing the light. This occurs when the patient has lost attention, it is fatigued, or is incapable of pressing. Like I think some of you must have also lost attention, and there may be some certain false negatives in this presentation also. So this is what happens with the visual field also. So mean deviation will show a high negative value. That means the retinal sensitivity, overall retinal sensitivity will be lesser as compared to a normal patient, normal person. Again, pattern standard deviation will be high here also. Then we move on to the raw data. Raw data is this grayscale and this numeric data, which is easily comprehensible in this picture. It gives you light and dark shades. Here we can see there are certain darker areas and lighter areas, depending upon the threshold change. They are useful for identifying the common artifacts and making the patient aware that, look, this part of the visual field is defective. It is very important that these two adjacent points should not be compared, because we all know that as we move from center to periphery, the retinal sensitivity decreases very sharply. This can cause depression, depressed areas because of the age, or the cataract, which can cause depression in this generalized sensitivity. It is not so important in terms of interpretation of glaucoma, because this does not signify very much in the hill of vision. Now we move on to the total deviation plot. Now this is an important area. Total deviation means that how much this patient's sensitivity overall is depressed from a normal individual. Like we talk about sea level, say Jaipur is at a lower sea level as compared to Kullu Manali. So overall, the topography of Jaipur is lowered as compared to what we talk about from any other hill station in country. So we are at a sea level which is low. So this is a total deviation plot which talks about generalized depression from the age matched normals. A deviation of 5 decibels is taken as abnormal. So we have to give some leeway in terms of the normals, range of normals. So positive number indicate a more sensitive point as compared to normals, and negative number indicates less sensitive point as compared to normative values. Now this test is center weighted. Center weighted means the center points are given more weight as compared to peripheral points. And anyway, we are looking at the central 20 degrees for glaucoma. So these are to be weighted more. Now this is good for overall visual field loss, but it is not generalized. It is not good for looking at the focal defects. So as I mentioned, our sea level, the sea level of Jaipur is lesser as compared to the hill stations. But within Jaipur, we can have areas which are higher in topography as compared to other areas which are lower in the topography. So this talks about a generalized area, generalized topography of sensitivity of the patient as compared to age matched normals. Now this pattern deviation talks about local defects. Now we are talking about elevated areas or depressed areas within the patient's visual field, not as compared to what is happening with the other normative database. So this is a localized area where we have potholes or we have hills in the visual field of the same patients. So what the perimeter does, it removes the 7th most sensitive non-edge point, takes that as a point as a reference point, and decreases the value of all other points with reference to that. So this identifies the focal defects of glaucoma. So effects caused by refractive errors, age, and cataract are removed. And in early stages, we can see there are defects in the areas, but sometimes generalized depression can also be a part of glaucoma, which could be misleading. And in the end stage glaucoma, as almost all the points will be equally depressed, so there will be a reversal of pattern deviation. That means the pattern deviation may not show up any defect, but it will be seen in the total deviation. So if whole Jaipur is dug out at the same level, so it goes further down the sea level, but there are no potholes, there's nothing left as to consider. So for most of the glaucomas, pattern deviation and the total deviation plot will show similar kind of defects. So pattern deviation plot symbols absent in the total deviation are usually false positives. Now we move on to another parameter, which is glaucoma hemifield test. Now what it does, it compares these 5 areas above the horizontal raphe as compared to below the horizontal raphe. So for normal people, they should be comparable and they should have kind of equal sensitivity on both sides, superior and below the above and below the horizontal raphe. So if there is a difference of p-value less than 0.01%, or between the two zones, or any two member of these zones have a p-value of less than 0.005%, then it is marked as outside normal limits. If there is a difference between the two hemifields, but it is not statistically difference, that the p-value is less than 0.03, then it does not reach a significant level, so it is labeled as borderline. Then we have generalized reduction of sensitivity, where almost all the points are lesser as compared to what we see in normal. So it is caused as generalized reduction in sensitivity, which could be because of cataract or refractive error or age related, or even retinal problems like diffuse coronary retinal degenerations. Then there will be abnormally high sensitive when the points are abnormally high as compared to normals, and then which is within normal limits when there is no significant difference from others. So this 5 kind of notations will be filed, which we can find in glaucoma hemifield test. Now we move on to the global indices. All these global indices are center weighted, that is central points are given more weight as compared to peripheral value. Peripheral points, a p-value of less than 5% is has a high probability of being abnormal. The mean deviation is the deviation from the age-matched normal database. So a mean deviation of more than 2 decibels here should arouse a suspicion of glaucoma. Pattern standard deviation is the difference between the threshold from one area to another, as we have already discussed. And this pattern standard deviation also should arouse suspicion of glaucoma if it is little high. Then we use a new parametric which is seen in the most of the visual field these days, is a visual field index. It's a single metric which represents the whole visual field as a single percentage of normal. So it is based upon the pattern deviation initially in the early glaucoma, but it can shift to total deviation with advanced glaucomas. So a patient who is having a full visual field or perimetrically normal will have a VFI of 100%, and a patient who is perimetrically blind will have a VFI of 0. So this VFI gives you a linear representation of patient visual fields in one single numerical value from 0 to 100, and it can also help us look at the progression of visual field. Then there is a gaze tracker. Now this gaze tracker follows the patient's cornea and records the movement. So any of the hot seas residents, can you tell us what this gaze tracker records means by this upward spikes and downward spikes? Tamanna, Ayushi, and Mukesh.
Come on, speak up. You can be wrong also. Just speak up.
So just because I know I've taken 15-20 minutes of very boring area. Now let us move to a little exciting or maybe interactive part. Can
Ayushi,
it be right, left, up, down, being monitored, not monitored?
you can type in the chat box also. Anybody can type.
Okay, so we move forward. So this gives you spikes in terms of upward and downward spikes. The taller spikes mean the greater deviation from center, but downward spikes represent the situation when fixation was unrecordable. That means that the recording of this track is not available. So downward spike doesn't mean that the patient has moved in the other direction. Downward spike means the patient's track was not available, not recordable. And the height of spikes tells you how much the patient has moved. Now let us, we have to remember these minimum criteria for glaucomatous damage. The GST has to be outside normal limits in at least 2 visual fields. A cluster of 3 or more non-edge points. Non-edge point means that the points which are at the extreme periphery, and they should be in the typical location of glaucoma, which are depressed by a p-value of less than 5% in the PSD plot, and one of them has to be depressed by a p-value of less than 1% in 2 consecutive visual fields, or a CPSD which is less than 5%. But this was there in the older visual fields. Now we have pattern standard deviation as compared to corrected pattern standard deviation, because they used to have different kind of strategies before the CETA came in. So we have PSDs, which is less than 5% on 2 consecutive visual fields. So these should be there to label a visual field as glaucomatous. So this you have to remember. And then there are these Hodop-Parrish classification, which are used to classify the visual field defects into mild, early, moderate, and severe. So if the mean deviation is less than 6 decibels, it is early. 6 to 12 is moderate. More than 12 is severe visual field defects. Less than 25% of points on 30-2, that is 18 points. If they are having a p-value of less than 5%, is early. If there are 37 points having a p-value of less than 5, then it is moderate. If there are 37 or more points having a p-value of less than 5%, is severe. Similarly, we have points having a p-value of less than 1%, like 10, 20, and more than 20 as early, moderate, and severe. And this central 5 degree is important because all the 4 points in the central area should have a sensitivity of more than 15 decibels. No point with 0 decibels, and only one hemifield with 1 point less than 15 decibels is moderate, and at least 1 point with 0 or both hemifield points with less than 15 decibels is severe. Because we know when this is reaching the central 4 points, we are threatening the macula. So this is given a very important point in classification of early, moderate, and severe glaucoma. Now I would want any of these Tamanna, Ayushi, and Mukesh to volunteer and let me know that is this glaucomatous, because this is how we want to learn about the glaucoma, visual fields in glaucoma. So, Tamanna, would you like to read this visual field? How do we classify this as glaucomatous or non-glaucomatous?
The GHT is outside normal limits.
Great. You're absolutely
Then
right.
the visual field, VFI is also 70%.
79%.
79%.
But in the glaucomatous visual field defect, we did not use VFI as a criteria.
Yes.
Right? Because
yes.
VFI is a newer entrant into the visual fields, although it has been many years, but it is not there in the identification of glaucomatous visual field defects. So what we have is these 3 non-edge points, right? So first
Yes.
thing was the GHT, second 3 was 3 non-edge points, right? So we have more than 3 non-edge points having a p-value of less than 5% and one of them having a p-value of less than 1%. So you can see these 2 points. These are the darker points, and we have many points who are less than 0.5%. Correct, Tamanna?
Yes, sir.
And what was the third criteria?
PSD is less than 1%.
Yeah, PSD is less than 5%. So here the PSD is less than 0.5%. So is this glaucomatous?
Yes.
So we all agree as per the classification is this glaucomatous, right? So now we move on to try and classify this as early, moderate, and severe. So we talked about the mean deviation being 6 to 12, and more than 12, right? So this is 7.66. So this falls into moderate, right? Mukesh, is it okay?
Yes, sir.
Yeah. So then we have a number of points which are more than having a depressed p-value of less than 5 and less than 1. So we have 28 points and 16 points. So 28 point means we had more than 18 points but less than 37. So again, it falls into moderate. One, we have more than 10 but less than 20 points. So again, it is moderate. So this falls into moderate. These 2 points fall into moderate visual field defects. But the problem is this, right? So one of this is less than 15 decibels, right? So we talked about for moderate, should I go back? So this is what we were talking about. All points should be more than 15 decibels. None of the points should be less than 0 decibels. And if there is only one point with less than 15 decibels, then it is moderate. And if there is one point with 0, it is severe. So in this case, we have, so we move on to the next slide. So in this case, we have mean deviation falling into moderate. We have number of points falling into moderate. We have this point making it severe because it is less than 1 or 0, right? So this means it is threatening the macula. As per this 30-2, although 30-2, we cannot say it is a macular split, but this is less than 1 decibel. So probably this is a visual field defects, probably yes. Then is it moderate? It is moderate to severe based upon the criteria. And this is the fundus picture of the patient. So we can see there is a disc hemorrhage here. There is a nerve fiber layer defect, which we can clearly see. These are the optic disc of the patient. Let us have a closer look. So this is the visual field defect. This is the nerve fiber layer thinning or the notch here. There is a retinal disc hemorrhage here, and this is the nerve fiber layer loss, which we can talk about. So this loss is being represented in this visual field as glaucomatous visual field defects. So we feel that we all are in consensus that this is a glaucomatous visual field defect. Now, Ayushi or Mukesh, who wants to volunteer for this visual field? Fast, बच्चे बहुत time हो जाएगा नहीं तो. Okay, Mukesh, are you taking up?
Mild glucomatous visual field defect.
Great. So you went on to analyzing it to mild. So let us go step by step. GST is outside normal limits. Then we have a cluster. We have a cluster of 3 non-edge points having a p-value of less than 5% and one of them having a p-value of less than 1%. And PSD is less than 0.5, less than 0.5%. So this falls into the Anderson's criteria of glaucomatous visual field defect, right? And then we move on to mild, moderate, and severe. So this is 5. So this is less than 6, probably a mild defect. Here we have 26. So this is more than 18 and 16. So this is more than 10, but less than 50%. So less than 37. So it is between 18 and 36. So it is probably moderate. And then we have no points, which is less than 15 decibels. So again, it is mild. So you were absolutely right looking at this visual field. It is probably yes, glaucomatous and mild to moderate kind of a visual field defect. But if the discs are like this, what do we do now? Now, do you still think it is glaucomatous, Mukesh?
Sir, on basis of this, we can't say this is glaucomatous.
Yes. So any visual field which is not fitting into our clinical scenario has something wrong. So we do not consider this as a glaucomatous visual field defect, because in the criteria, it talks about in the expected area. So looking at the disc, this is not a kind of visual field defect you will expect in these kind of discs. So what we do is we repeat visual field defects. So once we repeat, the visual fields are absolutely normal. GST is also borderline still. Mean deviation is less than 2, and there are no significant visual field defects. The cause here was a drooping lid. So after lid taping, it was absolutely normal. So this is other eye of a glaucomatous patient, which is not showing glaucoma. So always check palpable aperture and pupil size whenever we are administering a visual field in the patient, right? Now we talk about various kinds of scotomas. So this is a scotoma, which is paracentral scotoma. So this is the central area, and this is nearly, in continuation with the optic disc. And these two are paracentral scotoma. They represent partial notch or loss of axons. What can you talk about this, Ayushi? Do you think what kind of scotoma is this?
Anybody, what type of scotoma?
Nasal step. Nasal step.
Absolutely correct. So this is a more widespread damage, which is called as Roney's nasal step. So this is an area which is honoring the horizontal raphe. This is above the horizontal raphe. This is below the horizontal raphe. Add is in the nasal area. So these are nasal step called as Roney's nasal step. Anybody who can talk about these kind of visual field defects we expect in glaucoma?
Arcuate defect.
Arcuate. Very good, Mukesh. Do you have a name for this arcuate defects? So this is the result of notching where the nerve fiber layer lost or has lost to an extent where the disc margin is being involved, and they are called as Jerum's arcuate scotoma, and this is called as Jerum's area, right? And then there can be a combination of visual field defects which can occur in a patient in the superior and the inferior raphe. So this is a biarcuate scotoma. You can look into pattern deviations. This is a full arcuate here, and this is a full arcuate here. This is an arcuate here and a nasal step in this area because it is not crossing this part in this quadrant, right? So this is an arcuate step with a nasal arcuate scotoma with a nasal step. Then there can be a combination like arcuate, which is almost coming in from the optic disc to like this. And then there is a generalized depression, right? Then there could be a generalized depression with a nasal step. So these are the various kinds of defects which we see in glaucoma, and then there can be various combinations. Now, would anybody like to comment on this visual field defect? Ayushi, you are keeping quiet. बेटे कोई फर्क नहीं पड़ता हम गलत हैं तो. Okay, so now once we have a look at the disc, we can see there's a nerve fiber layer thinning in the superior area, and this thinning is corresponding to this defect here. Okay, so this is an arcuate defect in both the eyes, but this is improving, right? This is of 5 2015, and this is of sorry, this is of 7 2015. This is of 2 2015. So this is after 5 months of the first visual fields. So this is an inferior arcuate with a superior notch, and this variability is because of learning curve. So whenever we ask the patient to perform the visual fields repeatedly, they tend to learn the visual field gradually, and the visual field scotoma should be there in at least 2 consecutive visual fields, right? Now, anybody who can comment on this visual field? So we have this grayscale, the numeric data, the total deviation, and the pattern deviation plot, which has been taken out from the overview analysis. We have mean deviation and PhDs also here. Everything is represented in this small area. Tamanna or Mukesh, Ayush is keeping quiet. Okay, so I'll move forward.
Sir,
Yeah, go ahead.
Mild glaucomatous changes.
No, first we have to identify that this is an inferior arcuate, right? And since it is, it can be a mild visual field defect because this is there. I have not counted a number of points, but it is mild to moderate because the points are a little larger. They are more than, definitely more than 18 points, right? So it could be a mild to moderate defect. And we can see a small thinning of the superior NRR in this disc. And this can be compared with the other eye. Now, if you look at this thinning, you can easily perceive the difference between the two discs. So we have to compare the other eye disc as compared to this eye disc to actually label this as glaucomatous or thinning of the nerve fiber layer or thinning of NRR, right? Neuroretinal rim. Now, what is this? This is an advanced glaucomatous visual field defect with severe constriction. So I won't ask you for this because this is a 10-2 visual field. That is, we have just measured 10 degrees from the center of visual field. So this is around 3, 3.3, 6.9, and then 10 degrees. So this patient is having a very small visual field by a couple of degrees in this area and around 6 degrees like this. So this can be called as a perimetrically blind patient. This is a very advanced glaucomatous visual field defect. Now, what is this? So I have already come. This is a rim artifact because of improper lens placement. So as I told you, if the lens is placed away from the patient's eye, it is going to give you rim artifacts. Now, what is this, Mukesh? Tamanna?
Clover leaf pattern.
I would take it as a reverse clover leaf, right? Clover leaf is the reverse of this. This is excessively high false positive. So this is a white scotoma. So what we see is these areas are absolutely white. That means this patient's sensitivity is much more than what is of a normative database. And this is once we explain the procedure again. This is again the other eye of the patient, a glaucomatous patient. So what happens is the patient is a trigger happy patient. He just want to press the trigger, tuck, 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 tuck. Okay. So this is a white scotoma or a trigger happy patient. Now this is a patient. I'll just tell you a story of a patient, a 61-year-old male, diagnosed as glaucoma both eyes. PI has been done, well controlled on medications. Discs are 0.9 and 0.3, and he presented to us in 2007. It's a very old patient of ours with increasing defects, and it was advised a filter surgery in the right eye. So once we look from 2001 to 2007, his mean deviation is increased from moderate to a severe level where it has crossed 12. The pattern standard deviation is also gradually worsened. The GHT has gone from borderline to outside normal limits, and we can also see that these defects are increasing gradually, right? In all these visual fields. Also, there is an increase in the generalized depression. So, and based upon this visual field defect, he has been advised a filter surgery. So what we do is we repeat the visual field at our center, and then we realized that this mean deviation has dropped to below what it was in 2005. The PSD is also slightly bettered, reaching somewhere around 2006. GST, yes, is in the outside normal limits, but the visual field defect in the PSD area has improved. The problem here was somebody has done a left eye field right eye visual field in the left eye program, and then they just omitted and put right here. So what happens? The software identifies blind spot as a pathological scotoma, and the software's blind spot is seen by the patient. So, and this increase in mean deviation was because of the increase in the cataract. So we go back and see the visual field of these patients. So this patient is not worsening so fast. He's probably pretty well controlled with the medication and doesn't require a filter surgery. It does has advanced from 2001 to 2011, but this kind of slight changes in the glaucoma do occur in over a period of 10 years, right? So we have to be very, very sure that which program is being used for which eye. This is the lesson learned from this patient. Now we move on to another. So this was a 45-year-old female presenting with vague complaints of ocular discomfort. There is a strong family history of glaucoma. Mother and maternal grandmother has lost vision. She's a hypermetrope, but the angles are open with a narrow entry. Discs are absolutely healthy. And these are the visual fields she came to us at presentation. So this is on 4th of August, 7th of August, twice it has been done. We see there is an inferior rim kind of an artifact here. We see abnormal or bizarre kind of visual field defects on first. In the second one, the blind spot is not being measured.
Actually,
so this is the visual field we repeat on our center, and we see that there's a generalized depression. Again, this generalized depression is not fitting into the patient scenario. So we kept on thinking what wrong has been done with this patient. So I accidentally asked my perimetrist, what have you done? So what he did was he used minus 3.5 in place of plus 3.5. So this was the difference. The moment we kept the correct, power into the lens, the patient's visual fields were absolutely normal. So this patient was also allied medical, sciences. She was a nurse, and she was very much apprehensive because of the glaucoma she had in her family, and she was very worried. So once she had a normal visual field, she was actually pretty well. She was happy and to go back from us. Now, what is this? Ayushi, Tamanna, somebody talked about
clover leaf pattern.
So this is what is a clover leaf pattern. So clover leaf occurs when the patient is fatigued, inattentive, and loses interest after initial pattern. So this is what is a typical clover leaf we have. So what patient does is it responds in the central part where the central visual fields are being taken, and then he forgets to respond. So this is a clover leaf kind of a pattern, and it is absolutely unreliable. Although the parameters are not bad here, you can see the time duration required is little more, but despite of having normal pattern, this is still a clover leaf. Now, this is a 76-year-old diabetic, hypertensive old lady with a borderline IOP, presents with sudden difficulty in vision. And she had a borderline IOP. She came to us, so we did a visual fields first, and this is the visual field defect it turns out to be. So does anybody think it can be glaucomatous? This is the disc, because when we look through 90D, this is the disc we can see. So is there something abnormal in the disc? So what you can see is small amount of retinal hemorrhages. And these hemorrhages are all around, more so in the inferior part, right? And this is the fundus picture.
BR view.
So this is a BR view, right? So the patient is a hypertensive, diabetic, borderline IOP. We all know diabetic patients tend to have glaucoma a little more than at least 4 times more than the normal population. And then the problem was sudden difficulty in vision. So sudden difficulty is not usually a part of glaucoma, especially with the borderline IOP, because you can have an acute attack but can have a difficulty in vision, but not with the borderline IOP. So this was acute BRVO this patient had. Now, can anybody tell me what it is? Vishal, can we make this as the question for the grand prize?
Kinetic perimetry, Goldman's kinetic perimetry.
Okay. If this is, that's absolutely correct. It is kinetic perimetry. What do these 1,4E and 1,4E represent? 1,2E, 1,3E, 1,4E?
Isopters.
Isopters. What is the meaning of 1,4E? You're absolutely right. This is a Goldman perimetry. It is rarely seen these days, but this was a perimetry which was usually done for neurological visual field defects. What does these 1, 4E represent?
No, sir.
1, 2, 3, 5 are the size of the stimulus.
Very good. Okay, so what happens is Goldman perimetry allows you to change the size of the perimeter and the intensity of the stimulus. So this 4 represents the intensity which is written here. So it starts from say 1, 2, 3, 4. So 1 is 15 decibels, 2 is 10 decibels, 3 is 5, and 4 is 0 decibels. That is the maximum intensity, right? So as we and this E is 1, 2, 3, 4, 5. So this is 5 decibels and E is 4 decibels. So this becomes 9 decibels attenuation. So this is how it is labeled, and this is the blind spot of a Goldman perimeter. So this is a Goldman visual field report, which is rarely seen these days, but yes, it's a kind of kinetic perimetry and still is the gold standard for neurological field effects. Now, can anybody tell me what is this? Ayushi, Mukesh, or Tamanna?
Bitemporal hemianopia.
Binasal.
Okay, the one who told binasal, why do you think it is binasal?
Bitemporal.
Why did you make it bitemporal now? Because I asked you it is binasal.
No, I read opposite eyes.
Yes. So I purposely placed this into a different manner. The right eye's visual field should be kept on your right hand, and left eye visual field should be kept on your left hand. Then you can identify this as proper. So this is a bitemporal hemianopia. You're absolutely right on Goldman visual field. And what would be the probable diagnosis?
Pituitary.
Pituitary adenoma.
Something which is pressing upon the chiasma, most likely pituitary adenoma, right? So this is the temporal disc pallor, the fundus picture of this patient, and this is the pituitary adenoma the patient has. He also gave a history of importance for last 2 years because of his high levels of prolactin. So this was definitely a pituitary adenoma. Absolutely correct. So now we talk about the neurological visual field effects. We have to understand that there is nasal retina in the temporal nasal visual field in the temporal retina. The nasal retina takes care of temporal visual field. Now it is correct, and the temporal retina takes care of the nasal visual field because they cross, and then these fibers cross and go to the lateral geniculate body. I mean, these are the optic nerve. They come to the optic chiasma, then they cross the midline. They form the optic tract. Then they go to the optic lateral geniculate body, and then they form optic radiation. So when the lesion is at the optic nerve, we have monoocular vision loss or monoocular blindness. If there is a tumor which is pressing upon the optic nerve of one side, you can have visual field loss of one side. If the tumor is pressing upon the chiasma, more likely you can have a bitemporal hemianopia, as we have seen in this patient, just previous patient. If it is optic tract before the lateral geniculate body, it could be one-sided hemianopia. So if the left side is involved, it will be a right-sided homonymous hemianopia. If it is the temporal lobe involvement, it will cause a pie in the sky kind of a picture, quadrantinopia, because the fibers from the inferior part are representing the superior retina. If it is the parietal lobe which is being involved, like this 4, then we can have something like pie on the floor, which is because of the parietal lobe involvement. And then you can have these area which is involving the occipital cortex, which can have homonymous hemianopia, but the macula is being impaired. Can anybody tell me why the involvement at macular cortex causes macular sparing? Why does the macula get spared if the occipital cortex is involved? Do we have a reason? Okay, so the reason is there are two theories. One theory says that the macula is represented on both the cortices. Like the macula of the right eye and the left eye is represented on right as well as left. So even if one side is gone, the other side is seen. The second theory says that this part of the apex of the occipital cortex is supplied by the posterior as well as middle cerebral artery. So if there is a vascular compromise, the other arteries is supplying this tip of the occipital cortex. Both the theories are, accepted and refuted by each others, but this is the theory which says that that's why the macular sparing is there in the occipital cortex lesions. Now, where is the lesion? Tamanna, Ayushi, and Mukesh. So we have a visual field defect supposed to have a neurological lesion.
So right optical tract.
Optic tract.
So this again, the right eye is on the left side, left eye is on the right side, but anyway, we have a left homonymous hemianopia. So the lesion is in right parieto-occipital region. It could have been an optic tract or optic radiation, right? If you look at this, if whole of the optic radiation is gone or the optic tract is gone, it is going to create the same kind of lesion. So this is a massive parieto-occipital area which is involved, and this is causing this homonymous hemianopia. Another patient which is having a homonymous hemianopia of the left side with right parieto-occipital lesion in this patient. Now, what is this? What kind of lesion is this?
The pie
on the floor.
Pie on
Right.
the floor.
Pie on
Absolutely
floor.
correct. Very
Right.
right. So this is a pie on the floor, and the probable lesion is the parietal lobe of the
Parietal.
opposite side, right? So this is a left side pie on the floor, and we will be looking at the right side parietal lobe involvement. Absolutely correct. Now, what is this?
pie in sky. So
Pie in sky.
But we have the PL negative other eye. Pie in the sky, if you talk about pie in the sky, we will talk about a lesion in the temporal lobe, but this is not going to make the other eye blind. This is called as junctional scotoma of Traqueir. Now, this is very important. This is you look into the chiasma, how the fibers are arranged. So this is specifically seen, these inferonasal fibers, the one with the yellow, they travel from the optic nerve on the nasal side, they go more anteriorly, and then they go to the other side optic nerve, and then they travel back, right? And the macular fibers are here in the posterior part of the chiasma. So any lesion which is causing a problem here would cause complete knocking off of this eye and the pie in the sky of the other eye. So this is a junctional scotoma at the junction of the optic nerve and the chiasma. So this is very important. We have to understand this is caused the left eye superior pie in the sky and the right eye is gone. So this is having a lesion which is at the junction of the right optic nerve with the optic chiasma. So for neurological defects, both eyes are to be looked simultaneously. There are absolute defects. In the glaucoma, we see there are relative defects. Some points are darker, some points are lighter, and these defects respect the vertical midline. So this is the area, this is the defect which we talked about, pie in the sky with the other eye being absolutely knocked out. So this is something like a junctional scotoma. So now this is the Vishal, the question for your grand prize, because this is my last case.
So you have how many questions for the grand quiz? 2 or 1?
No, I have just kept this
Estremont
one question
test.
with 3 parts. Okay. Identify the visual field test pattern. You have to put in the box what is the answer for this.
So whoever gets all the 3 answers will be the winner. Not a single answer will not be eligible. Okay. So identify the visual field test pattern, how to perform it, what is the value. You can type your responses. You can type the responses.
How to perform means what care should you take while performing this kind of visual field test? Any 2-3 small points, and what is the value of this?
This quiz is open to everybody in the audience. Anybody can answer and type in the chat box and can be a grand prize winner.
Vishal, let me know when to move forward, then I can just talk about the answers. We need a winner,
so I'm waiting. Visual field test pattern, how to perform it, any 1 or 2 points, and what is the value? Can you elaborate, Dr. Ankur? What is the value?
Value means why do we perform this visual field?
What is the value of this test? Why is it significant?
Why it is significant?
Or driving license.
Type it. The verbal answer is not valid here. Another 10 more seconds. I think you have put a difficult question, Dr. Ankur.
Yeah, I was actually thinking while presenting that because people were not answering, I was thinking that it has become a little difficult.
We can have it in parts. You can answer the, the questions.
The maximum, the best suited answer will get the kind of prize then.
Fine.
So I move on to the answers then.
Yeah.
So the answer is Esterman binocular visual field test. This is absolutely correct. Two of the people had talked about Esterman.
Okay, Mukesh got it first. Okay,
so
fine.
The answer, the difference here is you have to keep not the eye but chin in the center. So this glabella has to be there in the center. Both the eyes to be open. Nothing is to be patched, and you have to move the patient chin rest on one side, which is in this right side, and push that chin on the left side of the chin rest, so that the patient is in the center, and none of the eye is to be patched. So the point would be no eye to be patched, keeping the patient head in the center and following the glabella rather than the eye. These are the few points which I wanted to highlight. And this is a mandatory requirement for Group 1 driving license for the developed countries, and Group 1 minded are car drivers. So ideally we should be seeing at least 60 degrees on either side. This is 80 degrees here, right? So at least 60 degrees on either side, that is 120 degrees we should be seeing for a good driving. Okay, so again, central 120 degree on either side for the horizontal meridian. So there are no defects in the central 20 degrees. This talks about 120 degrees as the normal driving requirement for driving of cars in the developed countries. I think in India also sometimes this will also come. So in the end, I would just like to say a peculiar arrangement of nerve fiber layer and typical pattern of loss is key to understand the various pathologies of the visual fields and various diseases which can be used, which can be predicted from these visual fields. And it is important to understand that we treat patients, not the visual fields. So visual fields, if they are not corroborating visual clinical scenario, should be repeated and omitted. Thank you, everyone.
Excellent. Thank you, sir. So the grand prize winners are who came close to all the three answers is Mukesh and Pushkar Raj. And your grand prizes will reach to your workplace or your residence very soon. But see Antod Pharmaceuticals. So thank you all residents, ROS executive, respected teachers who have logged in, and especially Dr. Ankur sir for the excellent teaching. We look forward to the next class in the coming weeks with more residents on the hot seat. Thank you, and keep giving your feedback for the Kaksha experience to improve. And especially, it was a very well explained and, very comprehensive presentation. It's advice to all of you, as Dr. Ankur said, especially the residents, to do the visual fields on themselves or their colleagues and not just wait for the printout to come out for an in-depth understanding of the knowledge of the topic. And do subscribe to the ROS official channel on YouTube. All the previous Kakshas and the current Kaksha are uploaded and is running live on YouTube also. Good night from Team ROS. Thank you, Ankur sir. Thank you, everybody.
Thank you, Vishal. Thank you, ROS. And thank you, everyone. I hope
the YouTube channel, sorry, there was a question. The YouTube channel is ROS Online. ROS Online. So you can search on the YouTube ROS Online and you can get all the classes there. And you can also join the WhatsApp Messenger. There's a link to the WhatsApp group also online. Okay. Thank you, Ankur sir.
Thank you, guys. Thank you.
Bye.
Bye.